Hello. Welcome everyone to Oncology Watch. Today's topic is adjuvant endocrine therapy and breast cancer, presented by Dr. Jenny Fox. Thank you for joining us today. Welcome,
Thanks.
Dr. Fox.
Thank you. Glad to be here.
So Dr. Fox is a medical oncologist at Rocky Mountain Cancer Centers in our Boulder office. She graduated from the University of Colorado Medical School, completed a residency at University of Utah Medical School, and her oncology and hematology fellowship at University of Virginia Health Sciences Center. We've been fortunate to have Dr. Fox with us for 17 years at Rocky Mountain Cancer Centers. While she sees patients for any type of cancer, one of her special interests is in breast cancer. Her combination of compassionate care with medical treatment allows her to work closely with her patients and their families on an individual basis. We look forward to learning more about adjuvant therapy from you, Dr. Fox. For our viewers, we're going to be monitoring the comments section during her talk. If you have any questions, please put them in the comments and we'll address them to Dr. Fox at the end. Thank you again, Dr. Fox. We're eager to hear what you have to say.
Thanks. All right, let me get this going here. I think that's, pardon me. Let's go back a little bit. I don't know why that opened up. Okay, great. Well, thank you. So I love to talk about this, and you'll see why. I just think it's such an important topic in breast cancer. And so adjuvant endocrine therapy for breast cancer. And when we think about just the term adjuvant, basically that means any treatment that is really designed to help prevent recurrence. So usually, surgery happens first, and then all our other therapies are really trying to reduce the chance of a breast cancer coming back, whether it's radiation or chemotherapy or adjuvant endocrine therapy that we'll talk about. And so just kind of as a roadmap, we'll be talking about these four things, basically. Why is it important? How does it work? What are the side effects? And then how can we manage side effects? So first off, why is it important? Anti-hormonal therapy, or the endocrine therapy for breast cancer, really has a significant impact on recurrence. So it decreases recurrence by anywhere from 40 to 50%, and that's a big improvement. And with our current treatment, including endocrine therapy, the 5-year survival for early stage 1 hormone-positive breast cancer is very good, over 95%, even higher than that. So these therapies result in a decrease in recurrence, fewer second breast cancers, so breast cancers potentially in the opposite breast, for example, and then help women live longer, improve survival. So these are really powerful medicines, even though they are pills. How does it work? Most breast cancers are hormone positive, about 70%, so more than 2/3. And what we mean by that is that a hormone positive breast cancer is either estrogen receptor positive, ER positive, or progesterone receptor, PR positive, but really any combination of those things. So oftentimes, very often, both ER and PR are positive, but sometimes just one or the other. So sometimes we'll get, a little maybe sloppy in our nomenclature and just say estrogen positive breast cancer, or anti-estrogen therapy, but know that also means ER negative, PR, progesterone positive breast cancers. Hormone positive breast cancer in any way is what we're talking about today. And so the reason that these are important is that hormones are really chemical messengers involved in cell signaling. Hormones of all different types really tell cells what to do. And so if we stay over here on this side of the slide here, we see estrogen out here. This is a cell, a breast cancer cell. And estrogen will come in, attached to the estrogen receptor. It's what it's supposed to do. And it's like a key fitting into a lock, and that turns the cell on. And this cell's machinery here in the nucleus basically is telling the cell what to do, divide, change, die, all of those different things. And so interrupting this signal really changes a lot of what signals those cells get. And so one of the really, I think, common and really good questions that a lot of postmenopausal women in particular have, so they'll say, gosh, I've been postmenopausal for 20 years, like there's no estrogen here. And it turns out that there is. And so estrogen can come from two different places. The most obvious is from the ovaries. So premenopausal women, virtually all, or the lion's share of estrogen comes from the ovaries. But it also is made somewhere else. And so that's especially important in postmenopausal women, and actually in men too, where the adrenal glands, which sit up on top of the kidneys, actually make a hormone, several hormones, androgens, which are male type hormones. And those hormones get converted to estrogen, mainly out in the soft tissues and fat, primarily by an enzyme that's called aromatase. And so you'll hear this word a lot as we're talking. So postmenopausal women, this is really the estrogen that we're targeting. Premenopausal women, it's really both, but primarily what's from the ovaries. And so that leads to the two broad categories of medicines that we can use for hormone-positive breast cancer, tamoxifen and the aromatase inhibitors. And the important distinction between these medicines is that tamoxifen blocks estrogen and the aromatase inhibitors decrease estrogen. And so tamoxifen, because it blocks estrogen wherever it's made, can be used in premenopausal women and postmenopausal women. The aromatase inhibitors, and there are 3 of them, their names are listed here, they decrease the production of estrogen, but only in that other pathway. They don't affect what the ovary is doing in terms of estrogen production. So these medicines can only be used in postmenopausal women or premenopausal women in whom we induce menopause, either with medications that suppress the ovaries or with surgery, removing the ovaries. And so when we think about how long do women take these medicines, it's a little bit of a changing target as we go because we're learning more and more. But for tamoxifen in general, 5 to 10 years. The 5 or the 10 is going to depend somewhat on the individual and what the features of their breast cancer are. The aromatase inhibitors, 5 years is really our current standard of therapy, although there are some studies that are demonstrating that some women may benefit from going longer with those medicines. And then there's also the option of sequential therapy, where this first option is essentially 5 years of treatment, but it's doing half with one and half with the other in either order. So first tamoxifen for 2 to 3 years and an AI for 2 to 3 years. And then tamoxifen for 5 years, followed by an AI for 5 years. And where this may be most often used is really in women who have very recently gone through menopause, and we want to make sure it's the real deal, that their ovaries are not functioning, or for women who are premenopausal and then become postmenopausal during those initial years of treatment. So 5 years in general is what to take home. So these next 2 things are really where we're going to spend the bulk of the time. What are the side effects? And I'm not going to go through an exhaustive list, but we're going to kind of hit what I think are the most important and the ones that people have a lot of questions about. So we'll kind of compare and contrast here. Tamoxifen, hot flashes, certainly very common. We'll talk more about that. The 2 things that are really important about tamoxifen, but thankfully are very uncommon, are these: blood clots, which are about 2 to 3 times higher in women on tamoxifen, 2 to 3% higher, and then uterine cancer, about 2 to 3% increase. And the reason for this is that tamoxifen has kind of this dual personality that we talked about, it blocking estrogen, but at some tissues, that estrogen receptor actually sees tamoxifen as like estrogen and creates pro-estrogen effects. And so that's why the risk of blood clots and uterine cancer are increased slightly, is that it acts like estrogen on the blood clotting factors and it stimulates the lining of the uterus like estrogen would. So very uncommon, but really important to know about. Tamoxifen actually has a positive effect on bone density. So the bone also sees tamoxifen like estrogen. So it's either neutral or helpful for bone density. And then in premenopausal women, Abnormal periods, irregular periods are not uncommon. It does not induce menopause for premenopausal women, but given the hot flashes and some of the menstrual changes, sometimes women think it does. And so let's move then to the aromatase inhibitors and kind of contrast these. Hot flashes, definitely common with the AIs. One of the good things about the aromatase inhibitors and why we often favor them in postmenopausal women is that they don't have that risk of blood clots and they don't have that risk of uterine cancer. On the other hand, joint stiffness is very common. We'll talk more about that. Negative effect on bone density, which makes sense. Our bones like estrogen, and so lowering estrogen is going to affect that. And so we carefully monitor bone density and have some directions in terms of how to prevent bone loss or treat it if it's happening. And then finally, sexual side effects. Sexual side effects, mainly vaginal dryness, are quite common with the AIs, again, because of that lowering estrogen. And so when we think about a woman, a postmenopausal woman, for example, who could take either of these medicines, remember, premenopausal women, only tamoxifen unless she has an induced menopause. So when we think about these, really these are the standouts in terms of how we might make decisions. The aromatase inhibitors are perhaps a little bit more effective than tamoxifen, but not head and shoulders. And so if a woman has had blood clots in the past, or maybe has a very strong family history, for example, we might say, gosh, you know, an aromatase inhibitor is really a better option on that risk versus benefit front. In contrast, if a woman has really significant bone loss, has osteoporosis and has had fractures, we might lean this way because of tamoxifen's either neutral or helpful effect in that regard. So these are the things that your oncologist is thinking about and talking with you about when making decisions about which medicine to take. And so how can we manage side effects? I'm really going to focus on three. There are a lot to talk about, but three in particular. And the reason why I think this is such an important topic to talk about is that about a third of women stop endocrine therapy early due to side effects, primarily these three: hot flashes, joint stiffness, and sexual issues, which is largely vaginal dryness. And remember what a powerful effect these medicines have. And so we really want to try to keep women on them for the recommended amount of time that we know works the best. And so we'll talk through these three and some options about how we can mitigate some of those side effects. So hot flashes, this is really common. This is a cartoon that I like because Kathy's hot flashes were becoming severe. And I always think about Kathy here on Pearl Street Mall here in Boulder. And so really common, 30 to 40% of women on either AIs or tamoxifen. And so that's, you'll notice, by no means all women. So it's not 100%. So sometimes we just have to start and see how it goes. And I'm not going to go through some of the simple things that people do, dressing in layers, maybe not to the point of a swimsuit, but layers, fans, that kind of stuff, which people are already largely doing when this topic comes up. Some of the more simple things that are options, supplements. We get a lot of questions about supplements, and particularly black cohosh, vitamin E, grapeseed extract, evening primrose oil, lots of different things. And if you go in any Vitamin Cottage or really any store, you'll find in the supplement section things that are marketed for postmenopausal symptoms or women's health, those kinds of things. And it's really important to look at the ingredients and talk with your oncologist about it. Placebo-controlled trials, which are small and not that many, unfortunately, show that there's mild benefit. So they're by no means home runs, but they might be somewhat helpful. And something I think that's important to think about is that the effect of a lot of these we think is probably because of their similarity to estrogen. They are plant-based or phytoestrogens. And there are some questions about whether those are safe in breast cancer. Most of these really appear, at least in small studies, really appear to be okay and not have significant risk associated with them. But again, the benefit's mild. Weight loss can be really helpful, as well as acupuncture. Several women that I see have acupuncture, and we know from the literature too that that can be helpful. So I think that's something to think about. More complicated things involving medications then are kind of our next step. And the first category are really the SSRI, antidepressants, selective serotonin reuptake inhibitors. At low doses, not necessarily antidepressant doses, actually can be one of our most helpful tools for reducing hot flashes. The most commonly used one and very well demonstrated to be effective is Effexor or venlafaxine. Celexa, citalopram is another. And then the original SSRIs, Prozac, Zoloft, Paxil, is really how we started realizing that these could be helpful. Now, there is a particular note to make about these three medicines. If a woman is on tamoxifen, there's some debate about if these medicines may reduce the metabolism of tamoxifen to its active form and whether or not that has an effect on its effectiveness. So certainly Effexor up here is fine to use, with tamoxifen. And so that's often the first one we'll go to. Neurontin or gabapentin is particularly helpful at bedtime. And the reason for that is that one of its side effects is it tends to make people sleepy. So if it's bedtime, that usually works out okay. So it can be particularly helpful for sleep interruption, nighttime symptoms from hot flashes. And then these last two, oxybutynin or ditropan is actually a medication for, strangely, bladder spasticity, but it's been studied in the reduction of hot flashes and is effective. Does have some side effects, dry mouth, and some urinary retention potentially, given its usual prescribing purpose. And then clonidine, which is actually a blood pressure medicine. We don't use this much anymore just because of some of its side effects of sedation and just feeling kind of fatigued, but certainly a number of things that can be used either singly or in combination to think about. So we'll switch gears to joint symptoms, and these are really primarily with the aromatase inhibitors, much more common than with tamoxifen, but not zero with tamoxifen. And so women will often just describe it like, I feel like I got really old. And kind of like, first thing you get up in the morning and you think, I am the Tin Man. I need to have, the oil can brought out and limber up. And so kind of the classic is joint pain, particularly joint stiffness, almost more than pain. So particularly in the morning or with an activity. So if you've been sitting at the computer a long time, watching a movie, in the car, those kinds of things. And so it takes some time to limber up. So kind of an exacerbation of what most of us feel to some degree as we get older. And it commonly affects smaller joints. So like the hands, ankles, knees, feet, hips, those kinds of things. And some reassurance, the aromatase inhibitors don't cause damage to joints. So they don't accelerate degenerative arthritis. They don't cause permanent arthritic changes. The symptoms really often improve over time. There have been some studies on this that have had questionnaires in the beginning and then at various points during treatment. And about half of women notice that at 6 months, they feel a little bit better. They notice those symptoms less. And then a big number, 75%, notice improvement at about 1.5 years. And then also reassurance that symptoms are reversible when the AI is stopped. And we'll come back to this as a strategy for how to manage. And I'll also add here, although it's not on the slide, having pre-existing arthritis does not necessarily predict how well someone will tolerate an aromatase inhibitor. So for example, women who have rheumatoid arthritis and already have a lot of joint symptoms, certainly more joint symptoms are going to be especially problematic to them, but having that RA, rheumatoid arthritis to begin with, doesn't necessarily mean that they will have more of those side effects. And so, we find that those joint symptoms are tolerable for most women. Definitely can be annoying, but generally manageable. In the clinical studies, of these medicines originally that led to their approvals, only about 10% had severe symptoms and only 2% needed to stop. But in real life, not in a clinical trial, up to a third of women stop the aromatase inhibitors due to side effects, and most often it's the joint issues. And so in clinical studies, there's a lot more of pill counting, counseling, motivation to stay on medications because women are in a study. And so again, I think this is just an illustration of why it's so important to know their options for these and to know the benefit of staying on these medicines, even though they can have side effects. Most often, if women have these joint symptoms, it's usually in the first 2 years. And so most often by 2 months. So if a woman has gone, 3 or 4 months and isn't really having much of a problem, it's unlikely that the other shoe is going to drop and she's suddenly going to start having a lot of joint symptoms. Almost always by 6 months, if they're going to happen. So it's very unusual to be on an aromatase inhibitor for 2 years and then start having joint issues related to the medicine. It's not impossible, but it would raise a question about, gosh, is there something else going on? Other arthritis, degenerative arthritis, those kinds of things. And so some strategies for managing joint symptoms. Far and away, the most helpful thing is just to keep moving. So it's like, again, like that Tin Man example, that once you get going, things improve. And so increasing exercise, particularly in the morning, morning stretching. And so this does not have to be, a crazy amount of exercise, training for a triathlon or something like that. It's really walking is great exercise, stretching, yoga, Pilates, low impact exercise, just keeping moving, standing up frequently when you're working at your desk. Weight loss and acupuncture, again, like with hot flashes, can be of help. Avoiding vitamin D deficiency, that sounds like kind of a clunky sentence there, but many people with vitamin D deficiency actually have achy joints. And so just making sure that that's not contributing, as well as the fact that vitamin D is good for bones and may have a role in breast cancer recurrence as well. Anti-inflammatories, ibuprofen, Aleve, that kind of stuff tend to be a little more effective than Tylenol, but both can be helpful. And then again, duloxetine is an antidepressant. It's also known as Cymbalta. That can be actually quite helpful in terms of joint symptoms. It's been well studied and also can reduce hot flashes as well. And then something I'll talk a little bit more about is just a strategy of changing between different aromatase inhibitors or the option of changing to tamoxifen, which certainly tends to have much fewer joint symptoms with it. And so when we think about, problems that women are having with the joints on an AI, first we want to sort out, are the symptoms due to the medication? Certainly is possible. And sometimes we need to have a trial off a medicine for 1 to 2 weeks to see if there's improvement. And this is where that idea of reversibility comes in that in a week or two, the vast majority of women with joint issues related to the AIs have significant improvement. And so it can be a strategy of figuring out, okay, is this just, arthritis that's going to be there and not change, or is it really something related to the medicine? And then in terms of another strategy for how to stay on a medicine, but to feel better, is to switch between the aromatase inhibitors or to tamoxifen. So remember, there are 3 different aromatase inhibitors. They are all really equally effective. They're more similar than different. And many women, over half, up to 2/3 of women, notice that they have improvement in joint symptoms when they switch from one aromatase inhibitor to another. And it turns out it really doesn't matter what direction you go. So if you start on one and it's not going well, try another. For women who maybe try all 3 and just don't find one that's a good fit, tamoxifen is an option. And the vast majority of women who have intolerable joint symptoms on the aromatase inhibitors do well with tamoxifen. So I think, I would just encourage folks, I think for women with joint symptoms on an AI, not just stopping it without maybe trying another one or looking deeper into it. Okay, so vaginal dryness. This is sort of a topic in itself. So we're just gonna, kind of skim the surface of that. But the main thing, if you take nothing else from this, would be that this is really common. Every oncologist, every gynecologist knows that this is a common side effect of the aromatase inhibitors because they reduce estrogen, and vaginal dryness is really common after menopause anyway. So be sure to bring it up with your doctor. Sometimes that might feel awkward or hard, but it's not going to be a surprise. And often there's just a lot to cover in each appointment, and sometimes you just don't get to that. There are lots of helpful tools there. So dividing up lubricants and moisturizers. So lubricants, think of that more as needed. So with sex. Water-based, KY, Astroglide, etc. are certainly easy to find and easy to use. Silicone-based, though, tend to last longer and be a little more effective. Astroglide Diamond is one. Ridiculous name, but that's what it's called. And then something else to remember is that oil-based lubricants. This is as simple as coconut oil, which is nice because it's a solid at room temperature and there are no other ingredients in it, can be really helpful. The only thing to know is that for women who are premenopausal is that oil-based lubricants should not be used with condoms because they affect the effectiveness of condoms. So lubricants. Then moisturizers, this is something to be used regularly, not just as needed. So think of it like kind of maintenance, like moisturizers for your face or your body if you have dry skin. Again, oil-based coconut oil is great for this purpose as well. And then some other products that these are not prescriptions, you can get them at least Replens and the KY liquid beads just at any store really. Reverie is a product that is a little suppository that's made up of hyaluronic acid, which is basically stuff that makes our joints slippery so that they work better. And so a lot of women find that this is helpful. And you can look that up online, but it does not require a prescription. And then a couple of things just, maybe to think about or that you'll come across as, you look into this is something called the Mona Lisa touch procedure, which some of the gynecologists are doing, which is basically laser therapy for the vaginal mucosa. And important to know, it's not FDA approved and it's not covered by insurance, unfortunately. But it may be an option for some women. It may be helpful for some. It's not helpful for everybody, but just something to know about if that's really an issue. And then the other thing is vaginal estrogen often comes up as a question. And I think it's a little beyond the scope of our time today, but I think it's something to just think about with your oncologist. And the concern here is that could there be enough absorption through the vaginal mucosa of estrogen cream that somehow that is circulating and then available to stimulate breast cancer. And so there are some different opinions on that, but certainly could be something to talk about if this is really a deal breaker kind of issue. So let me just wrap up again. We end where we started, which is really the whole idea that these medicines are really effective. They reduce recurrence by up to 40 to 50%, and that using them, women do better than without them. And so because of this up here, that up to a third of women may not complete 5 years of treatment because of side effects, we just really want to make sure that we're doing everything that we can to make these medicines as tolerable as possible so that women can get that benefit that's so important. Okay.
Thank you so much, Dr. Fox.
Welcome.
So I have a couple of questions that came up for me as I was listening to you, and then a reminder to our viewers, if you have any questions for Dr. Fox, please put them in the comments section, and we'll be happy to get those to her. One of the things that I was curious about is, are there any AIs or anti-hormone therapies that are used to actually prevent breast cancer?
That's a great question. Yeah, and so that would be somebody who does not have or has not had breast cancer, but say they have, a high risk for whatever reason, either because of their family history or, maybe a biopsy result that's not cancer, but something that increases risk. Yeah, and so tamoxifen, it came out before the aromatase inhibitors, but that has definitely been demonstrated to be helpful as a primary prevention medication. And so it reduces the risk of breast cancer by about half, by about 50%. And so that's a big number. It depends what a woman's risk is to begin with to weigh those side effects and blood clots, things like that. The aromatase inhibitors more recently were FDA approved for that same role, would be available for postmenopausal women. And then there's a medicine called raloxifene or Evista, which is very similar to tamoxifen, but has less of the risks associated with tamoxifen, which could be used in postmenopausal women as well. Yeah, good question.
Thank you. But yeah, that was really interesting to think about that. You were talking about a lot of the bone concerns with the estrogen, is there any concern with some of the bone density improvement drugs or supplements that are specific more to bone density interacting with these drugs?
Good question. No, so no overlap there at all. And so vitamin D, exercise, weight bearing, those aren't medicines, but, ways to help preserve bone density. But the anti-osteoporosis drugs are totally fine and we often use. And some of them actually may have some benefit outside of bone, but also actually for reducing breast cancer recurrence in higher risk women. So those are fine to use.
Great. And then there are some cancer patients, especially in women, that you see that are dealing with lymphedema. Is that a side effect of any of these drugs?
No, it's really a side effect of lymph node dissection, surgery, potentially radiation, but these medicines would not affect that.
Great. Some questions that are coming in, as we have one that says, does everyone have a single cancer cell in their body?
Does everyone have, gosh, I guess in terms of, I'll break that up. Probably it's weird to think about, it's creepy to think about, but we probably do, and our bodies, at their best, identify those and take care of them. But if we think about it in the context of breast cancer and this adjuvant therapy, really that's kind of the idea, is that as we're thinking through risks and benefits for an individual person, we're really thinking about, okay, gosh, after surgery and radiation, let's say, what's the risk of this coming back? What is the chance that, there is some little breast cancer cell that sort of got away and can set up shop somewhere and cause a recurrence in another part of the body? And that helps us sort out, gosh, a risk of that versus the benefit of medications. I'm not sure if I hit that on the head of that question or not.
Well, I certainly learned something from that one. So another question we got is, how does letrozole work in comparison to the ones that you've discussed?
Yeah, letrozole is an aromatase inhibitor, letrozole, anastrozole, and exemestane. And they are really more similar than different. They all inhibit that, remember that slide that had androgens, estrogen, and then aromatase? It inhibits that enzyme. And so all three of them do that. They may differ a little bit in their chemical structure, but they really all accomplish that same thing. So letrozole would be in that group.
Well, that's all the questions that we've had for this afternoon, I think. So Thank you again so much, Dr. Fox. Thank you to our viewers and future viewers. If you are watching this and want to ask a question, please feel free to leave a comment, and we will make sure that you get an answer on that as well. So thank you, Dr. Fox, for your time today. And this was very, very informational.
Oh, my pleasure. Thanks.